evening once again, sir.
Good evening.
Good evening, everybody.
Good evening, everybody.
Good evening.
Good evening, everyone.
Good evening, sir. Good evening.
Good evening, sir. Sorry we are late because that was back-to-back meeting of our executive committee, sir. So welcome, Dr. Vineet Talwar, sir, for this 90th webinar of our Enoch DigiConnect webinar series. And before we start, let me request our President, sir, Dr. Kumar, sir, to give the welcome address. I think he was calling me. So sir, Dr. Rajiv Jain, sir, you can give the welcome address. Dr. Rajiv Jain is our Vice President of AUSD.
Good evening, friends. Today is a special session. As you know, yesterday was the World Cancer Day, and the theme for the Cancer Day related to equity and how we should reach out to the people to be able to deliver comprehensive cancer care to people who do not get the care that they require to alleviate their suffering from cancer. And only yesterday, I was reading in the Hindustan Times, Dr. Vineet Talwar's article on immunotherapy. And immunotherapy is something which is so relevant now. Most of the research in the world on cancer therapy today is focused on immunotherapy. And within the medical oncology community, as Dr. Vineet Talwar would agree with me, that this is the future where it will make the difference in the quality of life of people who suffer from cancer. So today, besides the regular COVID-19 epidemiological updates, we would love to hear Dr. Vineet Talwar. And we welcome all the participants, and we would anxiously await your deliberations, and also would listen to you again on the DigiConnect YouTube channel. Welcome to all. Thank you so much.
Thank you, Dr. Rajiv, sir. Dr. Jain Kumar, President, AUSD. Would you like to say?
Good evening, friends. I welcome all the participants, as well as I welcome both our speakers, Dr. Vineet Talwar from Rajiv Gandhi Cancer Institute and Research Center, New Delhi, and Dr. Rajiv Kumar Jain, our Vice President. And topics, as Dr. Rajiv has already elaborated, are going to be very interesting and very, very informative, because the heading itself speaks volumes about it: immunotherapy, nuts and bolts. So I was wondering, so let us not waste time, and straight away I request Dr. Vineet Talwar to start the deliberation, and let us start the program with the deliberation of Dr. Vineet. Dr. Sandeep, please.
Yeah, thank you, sir. So, sir, Dr. Vineet Talwar, sir, as we have already discussed yesterday, there are a lot of nut and bolts to be tightened, because there are new therapies which are coming in the world for the benefit of the patient, and these molecules, although they are approved somewhere, but not in India, and they are in various development stages and trials. So, but they are definitely very, very much beneficial for every one of us, and whosoever is requiring them, although their cost part is there, but we can always extend the benefit to the survival and for the quality of life of the patients. So to introduce to you, sir, this association is Indian Association of Occupational Health. It has got more than 3,000 members across India, and we are Delhi branch of IUH, and we are Association of Environment and Occupation in Delhi. In Delhi, we are all from different corporates, from public sector undertakings, Indian Railways. So most of them are medical heads in their respective organizations. So a lot of policy decision we expect you will help us in making them. And we are, for the last almost 2 years, we are having these webinars every week for the benefit of our members, so that they are well engaged with the academic activities, and we don't feel isolated during this COVID-19 pandemic. And moreover, sir, for everyone of you, Dr. Vineet Talwar, he is DM in Medical Oncology and FRCP from UK. He is head of the director of the Department of Medical Oncology from Rajiv Gandhi Cancer Institute and Research Center, New Delhi. And Dr. Vineet Talwar is presently working in this department since 2002, and he had completed his DM from Adyar Cancer Institute, Chennai in 2000. And he is member of the European Society for Medical Oncology and American Society for Clinical Oncology and Indian Cooperative Oncology Network, Indian Society of Oncology, to name a few. And he had been awarded 3 orations from the Association of Physicians of India, Indian Academy of Clinical Medicine. And he was awarded with prestigious Chikitsa Ratan Award by the Delhi State Medical Association. He is also fellow of Royal College of Physicians, Edinburgh, and has also credited as a fellow of International Medical Sciences Academy, FIMSA. So a lot of credentials are there, sir. I've just enumerated a few, and this was just for introduction to everyone, that our faculty is quite qualified and experienced. So whatever questions you have, you just keep them in the chat box, or you can raise your hands after the session. And this session is also live telecasted on YouTube channel, on our Oncology Connect webinar YouTube channel. So Dr. Vineet Talwar, sir, the floor is yours, sir.
Thank you, Dr. Jain, Dr. Gajendra, and Dr. Sandeep for the kind words. And let me see if I can share my screen here. So can you see my screen?
Yes, sir. Yes, sir. We can see.
Right.
Very visible, sir. Yeah.
So I thought I will speak on a topic which is the latest burning topic in the medical armamentarium, that is immunotherapy in clinical practice. And I'll try to make it very brief and very basic so that we can build it up from whichever tangent all of you want to build it up. So William B. Cooley, as all of us know, is known as the father of immunotherapy. Now, why is it so? This is the reason. I'm quite sure all of you must be knowing about the Cooley's toxins. They were, he thought that a patient who had an inoperable cancer, infecting that area would have a side effect of shrinking the malignant tumor. And over the next 40 years, he kept on doing that in the bone tumor service at the Memorial Hospital in New York. And he injected 1,000 cancer patients with these bacteria and bacterial products, which became to be known as the Cooley's toxins, and had excellent results, and he published papers through that. So from Cooley's time till now, there's been a lot of evolvement as far as the treatment has been concerned, and we have gone away from surgery to radiation to chemotherapy. Then came targeted therapy, and now we are at the juncture of immunotherapy. So basically, immunotherapies are designed to harness the patient's own immune system directly to fight the cancer, unlike the chemotherapy or the targeted therapy drugs. So as I was saying, this is the new kid on the block. So this is the fourth modality of therapy which we are going to use, or rather which we are using now routinely in our day-to-day treatment. So what is immunotherapy? To understand that, we have to go to the basics, that is the nuts and bolts. All of us know that the important mediators of immune response are the innate and the adaptive. So innate is the one which is antigen independent, and adaptive is the one which is antigen dependent. So when we talk of the innate immune response, the first line of defense which is there in the body, which attacks the tumor cells without antigen specificity, and they are the natural killer cells, which are the main effector cells of the innate immunity. And they help in activating the stimulatory pathways to trigger immune response, and they inhibit the pathways that counterbalance the immune activation, such as the checkpoints. Whereas the adaptive immune response is a durable response that attacks tumor antigens, which once activated can be sustained through a memory response. And cytotoxic T cells are the ones which are the main effector cells of the adaptive immunity. So when you go around, what are the components of the immune system in the context of tumors? So you have a tumor here, as you see in this cartoon. The tumor keeps on shedding out antigens, which are known as TAAs. So these is the basic of the whole situation. So these tumor-associated antigens, which are released by the tumor, are the abnormal cell substances or proteins, which can be recognized and responded to by the immune system of our body. So whenever you have a tumor in the body, you have a shedding of the tumor-associated antigens, which can be again harnessed, and these tumor-associated antigens are taken up by the antigen-presenting cells. These take up the antigens from infected or malignant cells and process them into shorter peptide segments. Now, why is this processing done? This is to present these antigens to T cells, which are the natural killer cells of the body, to mobilize an immune response. The T cells, as all of us know, they are not activated de novo. So, these T cells play a major role in killing and infecting of the infected or malignant cells which are activated. So once they're activated, they help in perpetuating the ongoing immune responses. So you have the tumor-associated antigens, which are released by the infected cell, that is the one which is harboring the cancer. This tumor-associated antigen is taken out by the antigen-presenting cells, which break up these antigens into smaller fragments, and thus they lead to the activation of T cells, which are there. Along with the activation of T cells, there is another cell which is known as the B cell. And once activated, the B cells differentiate to become plasma cells, which can secrete large quantities of antibodies against a specific antigen. And once these antibodies are there, which are secreted by the plasma cell, they can tag antigen-containing cells for attack by other parts of the immune system or neutralize their targets directly by blocking important mechanisms. Another group of cells are there, which are the NK cells. These are the natural killer cells. They can attack based on recognition of antibodies on the cell surface. And they can also recognize infected or malignant cell innately without contact with an antigen-presenting cell or an antibody. So you have the tumor-associated antigen, you have the antigen-presenting cells, which process these antigens into smaller fragments and present it to the T cells, the B cells. B cells, when activated, generate antibodies. The NK cells directly lead to the tumor cell kill. So you have two different types of immunity, that is the adaptive immunity and the innate immunity, which I mentioned just now. So even in the adaptive immunity, you have the T cell mediated immunity and the humoral immunity, which is by the B cell. So B cell leads to generation of antibodies. T cell leads to the generation of the natural killer cells, CD4 and CD8 cells, as all of us know. So this is the basic schema of what happens whenever there is a tumor-associated antigen. That antigen gets logged on to the antigen-presenting cells, which in turn cause the activation of the T cell to an activated T cells. And when these proliferate, they recognize the tumor antigen on the tumor cell and then lead to apoptosis, which is known as the tumor cell kill or the programmed cell death of the tumor. So this funda has been associated with multiple drugs which have been used in the immunotherapy. More so because when the cancer cell is there, it avoids immune destruction and has a tumor promoting inflammation. And it tries to enable replicative immortality. So these drugs which are there, they are these inhibitors, the checkpoint inhibitors, which are there, which lead to the breakage of the tumor cells. So when you say immunotherapy, you have a gamut of drugs which can be used. One is the checkpoint inhibition, which I was trying to tell you, which is T cell stimulated cells, which are used to kill the cancer cells, T cell adoptive transfer, the therapeutic cancer vaccines, and the effector antibodies and antibody drug conjugates. So among these, some cancer cell vaccines are used in our clinical practice. We are routinely using checkpoint inhibitors, and we are also using now adoptive T cell transfer. So what is checkpoint inhibition? This is the backbone of immunotherapy in current practice. You have a lot of drugs which are targeted against the PD-1, PD-L1, and these are nivolumab, pembrolizumab, atezo, avelumab, and durvalumab. And these are the indications briefly for all these drugs. Suffice to say, they are covering almost all the hematological malignancies and the non-hematological malignancies, whether it is the Hodgkin's lymphoma, whether it is the non-Hodgkin's lymphoma, or whether it is malignant melanoma, renal cell carcinoma, head and neck cancers, lung cancers, breast cancers, urothelial cancers, to name a few. And these are the drugs basically which are there in an armamentarium. And at this point of time, every week a new drug is being initiated and it is being taken into the clinical trials in phase 1 and 2 and 3. So the commonest drugs which we are using nowadays is ipilimumab, nivolumab, pembrolizumab, atezolizumab, avelumab, and durvalumab. So they are basically used in situations or indicated in head and neck cancers, in lung cancer, in breast cancer, in hepatocellular carcinomas, in renal cell carcinomas, and also in bladder tumors. So these are the approaches. You can use only immunotherapy, you can add it with chemotherapy, or you can add immuno with targeted therapy, or you can add immunotherapy plus another immunotherapy. All these combinations are there and research is ongoing to see which would be the best combination in this scenario. So I thought I will share one or two cases in which I can bring into the notice as to how we are using this in our clinical practice. So this was our case. This is a real case. This is not taken from the libraries. This is a real case of metastatic RCC. Is a young guy who came with florid metastasis and he was bedridden on a stretcher and he had deranged coagulation profile. He had a deranged kidney profile, renal function tests, and he was having severe dyspnea, as you can see by the pleural effusion, which is there on the CT chest, and this was the X-ray. So we tried to stabilize him, and then after that, we gave him immunotherapy that was nivolumab. And you can see after 4 cycles of nivolumab, there is clearing of the right lung, which was almost opaque at the beginning. And the patient who came on a stretcher, now he comes walking to our OPD, takes the treatment in daycare and goes back in the afternoon. There's another case. This is, was a very hefty gentleman, carcinoma of the buccal mucosa. He was a chronic tobacco chewer. He had this cancer, and prior to the checkpoint inhibitors, he had received almost all kind of chemotherapy and targeted therapy drugs, and still his disease kept on coming back and back. So this was in November 2017, where you see this was the lesion in the neck on CT scan, and in January, after 4 cycles, it almost vanished, and he comes till date and he's in remission. This is again another case of the carcinoma of the urinary bladder, in which you can see the patient came with the florid lung mets here. This is just to show one site where the patient had metastasis. And here you see after 2 or 3 months, there is a partial response, at least 40–50% decrease in the tumor bulk. There's another entity in immune checkpoint inhibitors that is known as pseudo progression, in which the tumor becomes slightly more in size, and after a certain period of time, that is 2 or 3 months, the tumor starts shrinking. And this you can see in this case where you saw that this is the starting point. The tumor increases in size, and then after 2 or 3 months, it decreases in size. So this can be there with immune therapy drugs, because there might be a coating of the T cells around the tumor that leads to physical increase in size. But if the general condition and the performance status of the patient is not bad, then these patients can be continued with the immunotherapeutic drugs and can be monitored. And after a couple of months, you can see that the patient has had the desired effect. These drugs, it is claimed that they don't have any side effects, but then in 5% of times when the body's immune system goes into a disarray, you can have all kind of side effects from the eyes to the lung to the liver, pancreas, endocrine organs, skin, kidneys. So in Hindi, as you term, बेलगाम घोड़ा, जैसे घोड़ा बिगड़ जाता है, in 5% times it might, but fortunately in 95% times it works as per plan. Other modes of immunotherapy are again adaptive T cell therapy, which are there, in which CAR T cell therapy has come, which has revolutionized immunotherapy, in which white blood cells are obtained from the patient and they are sent to the manufacturing factory where the antibody coated cells are there, and they again are taken, expanded ex vivo, and again, put inside the person's body. So these work as a tailor-made therapy for that individual and can lead to cell kill. So this was seen in again one case of lymphoma, which has been published in the New England Journal of Medicine. Another vaccine which is there, that is for the carcinoma prostate. This is known as Sipuleucel-T, which has been used for the last 4 or 5 years for metastatic prostate cancer. So I think I'll stop here, and the favorite quote of Swami Vivekananda, that all power is within you and you can do anything and everything. But one should never give up in the endeavor of cancer treatment and keep on trying your level best, because improbabilities can give opportunities, as Winston Churchill said. I thank you for a patient hearing.
Thank you, Dr. Talwar, sir. This was a broad overview of how this chemotherapy or immunotherapy is now available for the clinical practice. And we will have definitely some questions with you, sir. And before that, may I request our president, sir, he has raised his hand, Dr. Jain Kumar.
First of all, I compliment Dr. Vineet Talwar for a wonderful presentation. Such a difficult topic explained in such a simple words that everything is clear to all of us. So my compliments, Dr. Vineet. Now I got 2 questions with you. Number 1, this pseudo progression, will it not be a deterrent to the patient coming for this treatment? Because once the condition deteriorates, so many a patient would like to break the treatment protocols. They will just run away. So is it happening, or they are mentally prepared before starting the treatment? Because in other modalities, such thing is not there. This is what I understand. So this is my first question. And my second question is, how this therapy is placed cost-wise vis-a-vis other therapies?
So, sir, the first question, pseudo progression. Actually, what happens is the T cells, they coat over the tumor, and that leads to the physical increase in bulk of the tumor. So likewise, when you have pseudo progression, you have an entity which is known as hyper progression. So in hyper progression, the clinical condition of the patient rapidly deteriorates.
Right.
So if you have a lesion like this, which has slightly increased, and the general condition and the clinical deterioration of the patient is there, that is termed as hyperprogression, in which we stop these drugs.
Okay.
If it is pseudo progression, then the patient's general condition is very well maintained.
Okay.
So that, we quote a term which is radiologically known as IUPD, that is increase of immune unknown origin. And we follow it up. We do a PET scan after 6 weeks, the general condition maintaining, we keep on the drug. And then we find that in these patients, mostly the size decreases once the tumor cell kill is there. So in pseudo progression, the general condition is maintained.
Okay.
So decision to continue the drug is clinical decision. Whereas in hyper progression, as you rightly said, the condition General condition just falls apart and patient goes to ICU immediately. So in that condition, we stop the drug.
Right.
Second is the cost of these drugs, as I was discussing with Dr. Sharma also, where all these drugs come under the ambit of the intellectual property rights.
Right.
So we don't unfortunately have any generics. Like in some targeted drugs, in breast cancer, the injection used to cost 2 lakhs when it was an imported injection. The same generic one, which is now there, that is costing just 16,000 with similar efficacy, with similar stringent quality standards. Because India is, not best, is not is equal as compared to any other foreign company as far as the quality indices are concerned. Most of the drugs are being exported from India to America, to Europe. And here, the cost is a problem. So how the companies are trying to bridge the gap is they're trying to have patient assistance plans. Like you purchase one, you get 2 or 3 injections free, or you purchase, say, suppose the dose is 180 milligrams, you purchase 100 milligrams, you get 80 milligrams free. So like that, they try to bridge the gap. But then I agree with you. The cost is astronomical as far as treatment is concerned for those patients who don't have any backup, as far as, from a company backup or
TPA.
TPA. A person has to be, stupendously rich to continue, mega rich.
Right. Thank you.
Dr. Rajiv Kumar Jain, sir, you have raised your hand.
Yeah. Thank you, Dr. Vineet, for a very simple and very comprehensive presentation. My questions are related to number one. Since one of the ways to get access to these immunotherapeutic drugs is through entry into a clinical trial, where one can get free immunotherapy because you are part of a clinical trial, where one could get information on the clinical trials and in the area of immunotherapy, which would be the website or address where one could get access to various immunotherapy trials being conducted globally. That's one. Second is, like you worked in Adyar Cancer Institute, like you worked like about 20 years back. How do you find the changeover from Adyar Cancer Institute and Rajiv Gandhi Cancer Institute? Has it improved over the year, the access to cancer treatment, or in what way these cancer institutes which have come up have helped in improving the cancer prognosis and outcome? And related to this is, what are the plans to link up the National Cancer Institute, which is coming up in Jhajjar, with other institutions which are part of the National Cancer Registry, since your hospital is also part of the cancer registry in Delhi at least, and all through that in the National Cancer Registry?
So yes, I am an alumni of the Cancer Institute Adyar, which was the first institute in whole of the country way back in 1954 to start the DM Medical Oncology courses. Dr. Jain, we have gone way ahead as far as the treatment at that point was concerned, and as far as the treatment drugs which are there in an armamentarium at this point of time. So I really don't know whether you can compare Cancer Institute with Rajiv Gandhi. Rajiv Gandhi is a trust-driven hospital. It's not a corporate hospital. We have our own leverages wherever we can. We try to help the patients by getting fundings from outside and also the intramural fundings. I can just give you an example in Adyar in Cancer Institute. how big is the finances which play as a prognostic factor when the treatment comes. So there was a boy about 6-year-old who came with his father. The boy had acute leukemia, and we worked up the boy. We did all the basic tests which were done, and then we discussed the treatment with the father. And to our surprise, the father said that he had just amount of money to buy 2 tickets. He had come from Andhra Pradesh. We had a drainage from Kerala, Andhra Pradesh, and from Tamil Nadu for our center. So he didn't have money to go back. He said that either he dies or you do something. So Dr. Shanta, who was the pioneer in the cancer treatment in the country, she,
Yes.
got a lot of funds from the corporates. And then it was decided any person who comes, after doing a stringent socioeconomic working, if they found that any person who was deserving, like this boy, that boy was kept with his father for 2.5 years for full treatment. And only after the treatment was completed, the boy went back, hale and hearty. So this is just one example, and we had, lots of cases like this which we used to treat there, which even if we want logistically, we cannot do in a autonomous trust-driven institute. So having said that, we are trying in our endeavor. One is to give genuine and a serious treatment which is conforming to the standard treatment nowadays. And we also have the cutting edge technology along with that. So that endeavor is there. Now your second question is where to find the clinical trials. I really don't know how you can apply for clinical trials abroad, but in India we have CTRI, the Clinical Trials Registry of India. So you can just log on to the website and you can find at a glance what is happening throughout the country. We are also doing a lot of trials. AIMS is doing trials. Tata Memorial Hospital in Bombay, they are doing trials. So any deserving patient who fits into the inclusion criteria can take the benefit of the registries or the clinical trials and get the treatment benefit.
Thank you so much. Actually, I was, remembering some of the relations in US. They were able to access through the National Cancer Institute and NIH websites and enter into clinical trials, and they could, get huge financial benefit and also improvement in outcome. So that there was an open access method where public could, get contact with the principal investigator and then think of entering a clinical trial. That is what my experience in people in the family in US has been. So,
yes, sir. The same thing is there now in India, CTRI. Whomsoever goes to do a clinical trial, he has to mandatorily log on with CTRI. So that one, everybody knows what you're doing. And second, you have to conform to the basic practices and, there should be no malpractice. Everything should be transparent so that the patient gets the best benefit.
That's a great initiative. Actually, Indian population will gain by entering into clinical trial, and oncologists will gain in getting the right kind of patients and a wide base of patients, the right kind of patients to be able to get into clinical trials, and good outcomes could be available. Thank you so much.
Thank you.
Same question is with me, sir, as I have discussed yesterday with you. Most of us, we are from government organizations and corporate hospitals, especially the public sector undertakings. And we have set medical rules which were framed before this development of all these new therapies, which have now emerged in the form of immunotherapy or PAPI therapy or targeted therapies. So these therapies, they have to be shortlisted as per the requirement, and the needful has to be extended the benefit of these therapies. So from your presentation and from our experience and what we have discussed with other oncologists also, yes, these therapies are quite helpful to the patient, but as you have rightly said, that there are patient assistance program plans and programs with these companies, and they basically they should be extended to these patients. But what is happening is these corporate hospitals, big corporate hospitals, they are just charging the whole of the immunotherapy charges. They are not extending the benefits of the patient assistance plans to the. So in fact, now we have to think upon some strategies, like in case if we want to extend these therapies to our patient, then some guidelines should be framed. So we would request you to help us out in this, like because many of the patients, because they do require these therapies, but we are unable to give them because our rules doesn't permit, and there are no clear-cut guidelines from the government side and from the medical oncologists also. So your take, sir?
You have a valid point, but as I told you, ours is a trust-run hospital. So whatever the benefit the companies provide to the patient, as per the patient assistance plans, we give it to the patients. We don't charge fixed rates. So suppose there is a patient who is deserving and who falls in the criteria of what the company is able to offer, we don't flinch. We give that benefit to the patient. I really don't know what is in the corporate hospitals, whether they pass on this benefit of patient assistance plan, but in our hospital, it is a norm. We try to help the patient as much as possible.
Same thing happened, like, sir, for many of our patients, when we talk to the company, they are ready to offer the clinical trial, this patient assistance plans to the corporate patients, but they have to be given in the corporate, in the hospital setup only, and hospitals, they don't agree. We have to purchase the medicine from their pharmacy only. They don't allow the patient to bring it from outside. So these sort of issues are there, and for which we have to brainstorm and come out with some solution for especially for the corporate patients.
Sure, it requires, you have to find a middle of the road path.
Yeah.
How you can juggle between the costs, the patient assistance plans, and every corporate hospital may have different criterias laid down as far as the billing and all is concerned. So I guess one has to sit around with them and thrash it out.
Yeah. In fact, we have from Scope, we have done a lot of research and analysis on this, and we have come out that drugs, immunotherapy drugs, targeted drugs, they are approved by FDA, and they are being used in different countries where it has been approved. But when it comes to India, the CDSCO actually they put it up to the subject expert committee group, and they in their routine meetings they definitely discuss these molecules. But some of the molecules, those who are approved and they are there in the approved list of drugs of that CDSCO, we do allow them, but many of them they are just under the review for the subject expert committee, and they are on the trials only. So that we don't allow, but still those patient also, these immunotherapies, they are quite helpful, what studies show. So we will definitely sit down and discuss all these issues, sir.
Sure, we can do that.
Any questions from any other participant?
Dr. Dulera has asked in the Q&A box.
Yeah, Dr. Ghanshyam Dulera, he has asked the immunotherapy in CA lung and its prognosis post-therapy. Dr. Ghanshyam Dulera, Factory Medical Officer from Navi Mumbai, sir. He is from Schindler Electrical India Limited.
So in CA lung, there is an explosion of markers which can be targeted. So you have certain markers like EGFR or ALK or ROS. So patient who does not have these targets as markers, these patients are then checked for the PDL1. You have these checkpoint inhibitors as PDL1 blockers. The higher the PDL1 rating, the better it is for the patient. Meaning thereby in metastatic CA lung, if you have a PDL1 rating of more than 50, then you can get the best benefit by giving these immunotherapy drug as a single drug. You don't have to add it to chemotherapy. If the PDL1 is less than 50, it should be 1 to 50. And in this situation, you can add immunotherapy plus chemotherapy and then get the best benefit. However, having said that, immunotherapy is not like a magic mantra where you give it and you get the desired result. Unfortunately, if you see across the board, you treat 100 patients with immunotherapy drugs, you get the so-called responses in about 30 to 35%. The so-called magic responses which are there. The second point is that if the patient is of poor general condition and poor health, these patients cannot be given chemotherapy drugs. So that is where the immunotherapy drugs can be utilized in patients of CA lung. So these patients should not have the targets, which are the markers for targeted drugs. Once they don't have that, then the immunotherapy drugs can be employed in these patients. I would just like to I just like to tell more, because you have chemotherapy, you have targeted therapy, and you have immunotherapy. So chemotherapy, we just institute into the body and try to create a cell kill. Targeted therapy is where you have certain targets which are sitting on the cancer cell and you target that cell. With the target, the cell blasts. Immunotherapy is you are trying to generate your body's response. You don't look for targets, you don't look for cancer cells. Automatically, the cancer cells killed. So in lung cancer, if you don't have these targets which are sitting on the cancer cells, like EGFR, ALK, ROS, MET, then in this situation, you check for PDL1. If the PDL1 is positive, in a metastatic setting, you can give these immunotherapy drugs. In stage 3, which is loco-regionally advanced CA lung, there also you can give these immunotherapy drugs as a maintenance therapy where you have got a maximum cell kill by either chemotherapy or chemoradiotherapy. So you can, use it in various kind of situations, provided you've got a good PDL1 scoring.
Right, sir. So cancer treatment now, it is more basically it is on the very micro level it is going.
We are trying to tailor it, we are trying to hone it further.
Yeah.
So that the quality of life of the patient is maintained.
Yeah.
The side effects are reduced to the minimum and the good effects are got to the maximum.
Right, sir. So this was regarding immunotherapy, and one more issue which is now, since research are being done at molecular level and a lot of new tests, they are also coming in the market. Like there is one test known as Oncotype DX recurrence score. So what I have seen, some patient, they go for just lumpectomy and some sentinel lymph node biopsy, and then they get their ERPR and other tests done, and their doctors, they advise you get this Onco DX recurrence score done, which costs about 3,20,000, and that test is not available in India. It has to be done from US. So our companies, we feel if some substitute of this test is available, whether to decide whether this patient requires chemotherapy or not, because what they say this test is for prognosis and protectiveness of the tumor, whether it will recur in future or not. So are these tests relevant, or they are not required in normal routine practice? Because what we have studied, reviewed the literature that in US, because the cancer chemotherapy is very costly, so that is the reason why these tests are more popular over there. But in India, I think in context with India, this tests are not so relevant. And if there is any substitute test like can assist test, are they equally important, or what is your take, sir, on this?
So, Dr. Sharma, as usual, you have hit the bullseye, because everything boils down to finances. Now, Oncotype DX is a latest advancement in which you have a score. The lower the score, the better for the patient. Now, this is used in those ladies who have a small tumor and who don't have any lymph node involvement in the axilla. So it was seen that when you give chemotherapy to these ladies vis-a-vis a lady who has a big tumor or who has a lot of lymph nodes which are positive in the axilla, there was not much difference in the absolute survival benefit. Seeing cancer, you gauge everything by the overall survival. So if you have a dent on the overall survival, again, preserving the quality of life, getting the maximum with minimum morbidity, then, it is warranted. And that happened with this test. And this was validated over a lot of trials. And it was found that in those ladies who have node negative pathologically tumors, small size tumors, they are the ones who can be offered this. So in India, what do we do is, it is elective. If you have the finances, you go for the test. If not, then we say that we give you about 4 to 6 cycles of chemotherapy. Because if you give 4 to 6 cycles of chemotherapy, that is equivalent to the cost of the test. Now, certain new companies have spawned up in India, and they have tried to bridge this gap. Those who cannot get it done abroad can assist, I told you. So if you want further information, we can have a heart-to-heart talk there in our institute. I can discuss it with the director of pathology. He would be aware of all the other tests which are available. But then there is no direct comparison between can assist and Oncotype. If you say which one is better or which one is inferior. So this is what India has to offer, and that is what US has to offer. But at the bottom line, the baseline is that you are worried whether giving incessant chemotherapy may not make a dent in the quality of life of the patient. So you want maximum out of minimum. Minimum treatment, maximum gain. So these are the ways or via medias by which we try to find out how we can reduce the detrimental effects of chemotherapy.
So if there's no other question, then sir, we can conclude this session, and we can thank Dr. Vineet Talwar for a elaborate discussion on this new emerging therapy for cancers, that is immunotherapy. And yes, it is quite effective and less toxicity than the chemotherapy, and we should definitely extend the benefit to the deserving candidates. And for this, we want you all oncology community to help the people who deserve, but they are being restricted because of certain constraints. And new molecules, they are coming day in and day out, as you have rightly explained, sir. We also go back and read out the this immunology, and overall broad view you have given, sir, but still we have to go and see the components of the immune system and how these therapies they are affecting these different molecules. They are affecting which component of the immune system, and accordingly it is reducing the or causing the apoptosis of the tumor cell. So this is a new science for every one of us, sir, and we will definitely be more wise with you all learned faculties, sir. So thank you very much, sir. We'll definitely
Thank you so much.
forward connecting with you at different forums, and we'll be having our annual conference after 2 months, sir, in March. We will definitely request you to.
I hope it is a offline and not a virtual meeting.
It will be hybrid. It will be hybrids.
Hybrid. Okay.
Yeah. So.
Very nice. Very nice.
So.
Thank you so much.
Right.
Thank you. Thank you, Dr.
Thank you very much, sir.
Thank you. Thank you, sir. Thank you.
Right. So with this, we come to an end of this first session where our learned faculty was Dr. Vineet Talwar. Day before yesterday was the World Cancer Day, and on this occasion, we thought we should better discuss a new therapy, which is.
It was yesterday.
It was yesterday.
Yesterday.
Fourth.
Yeah, on 4th. So it was really a new topic to discuss for every one of us, and you all might have also realized that yes, immunotherapy is quite effective, and although the cost factor is very high, and the decision is also, a lot of malpractices are also there in the market. But we have to somehow control these therapies, and it should be given, right therapy should be given to the right person. So with this, we conclude the first session, and now the second session is the COVID Epid updates by our respected Dr. Rajiv Kumar Jain, sir, who is also our Vice President. And I don't think he needs introduction again and again from us, but still I would like to say that he is a Senior Consultant Health in Indian Railways and a lot of vast experience. And he has been a resource person for us for last 2 years. At least every week we are discussing and having Epid updates from him and regarding mitigation of COVID-19 in our respective workplaces. And every month he is doing OcuHealth Escapes every Friday for us so that recent advances in occupational health locally, regionally, and globally, they can be apprised to our members. And lot of accolades, lot of awards, lot of fellowships are there to his credit. And may I request Dr. Rajiv Kumar Jain to start his COVID-19 Epid update.
His biggest qualification is he is Vice President of our association.
Yes.
Thank you so much, friends. Today being Saturday evening, now, as we do, this is the 55th episode of COVID Epid Updates, where we take epidemiological situation review of the COVID-19 pandemic, a pandemic which has hit after more than 100 years. Now, we are still in the pandemic, in the thick of the pandemic globally, as we should see with the data that we get to see in subsequent slides. But before we go on to the epidemiological data analysis, let's listen. Next slide, please. Well, Dr. Tedros Adhanom Ghebreyesus, WHO Director General, Dr. Mike Ryan, Executive Director, WHO Health Emergency Program, and Dr. Maria Van Kerkhove. Let's listen to them, what they have to say for the pandemic today.
We have, since Omicron was first identified just 10 weeks ago, almost 90 million cases have been reported to WHO, more than were reported in the whole of 2020. We're now starting to see a very worrying increase in deaths in most regions of the world. We're concerned that a narrative has taken hold in some countries that because of vaccines and because of Omicron's high transmissibility and lower severity, preventing transmission is no longer possible and no longer necessary. Nothing could be further from the truth.
Of course, as always, Dr. Tedros Adhanom Ghebreyesus, WHO.
It's premature for any country either to surrender or to declare victory. This virus is dangerous, and it continues to evolve before our very eyes. WHO is currently tracking 4 sublineages of the Omicron variant of concern, including BA.2. This virus will continue to evolve, which is why we call on countries to continue testing, surveillance, and sequencing. We can't fight this virus if we don't know what it's doing. And we must continue to work to ensure all people have access to vaccines. At the same time, it's also clear that as this virus evolves, so vaccines may need to evolve. Variants of SARS-CoV-2 may continue to escape neutralizing antibodies induced by vaccines against prior variants.
Dr. Mariangela Simao, Assistant Director General.
Today, WHO published a new report on the burden of medical waste from the pandemic, threatening human and environmental health and exposing the need to improve waste management. Health workers and members of the public rely on huge amounts of personal protective equipment, tests, chemicals, syringes, needles, and other disposable products to protect ourselves and others. But after we have used it, most of it ends up as waste. 30% of health facilities globally and 60% in the least developed countries are not equipped to handle existing medical waste loads, let alone the additional COVID-19 load. This potentially exposes health workers to needle stick injuries, burns, infection, and affects communities living near poorly managed landfills and waste disposal sites.
Thank you, Gunilla, and we'll start with Dr. Maria van Kerkhove.
But we are urging caution because many countries have not gone through the peak of Omicron yet. Many countries have low levels of vaccination coverage with very vulnerable individuals within their populations. And so now is not the time to lift everything all at once. We have always urged caution in applying interventions as well as lifting those interventions in a steady and in a slow way, piece by piece.
To actually start lifting restrictions.
Every country has to find its feet, know where it is, know where it wants to go, and chart its path. You can look to the experience of others, you can look at what other countries are doing, but please don't just follow blindly what every other country is doing. Chart your own path, as Maria said, based on your current epidemiology, your demographics, your population at risk, your vaccination levels, your population immunity, your access to tools, the strength of your health service. And each country can chart a path out of the pandemic by taking that approach.
Massive, and as you said, there are new Omicron variants.
So I think it's a transition phase for many countries, not every country in the same situation. Those countries who are making decisions to open up more broadly also need to be sure they have the capacity to reintroduce measures with community acceptance quickly if needed. So as if you open the doors quickly, you better be pretty well able to close it fairly quickly as well. And therefore it's important that we keep communities informed and maybe ensure that communities understand that measures may have to be reintroduced.
A1 Omicron, and is it something that people...
The two issues that were highlighted by the team from the WHO, the medical waste issue and the Omicron variant of BA.2. So we shall be talking about it in subsequent slides. Next slide, please. This is the situation of COVID-19 in India today. 1,27,900 new cases in the last 24 hours, 1,055 deaths in the last 24 hours, out of which 370 backlogs were from Kerala. We shall also talk about deaths and its analysis state to state. 16 lakh tests were done yesterday. 7-day average test positivity rate has been 11.4%. 13.2 lakh active cases are there, but they are shrinking by 5.7%. Total 4.21 crore cases have been there. But more important, the most important landmark during this week has been more than 5 lakh deaths have been officially reported till today. 169 crore vaccination doses have been given. Yesterday were 48 lakh vaccinations. If you look at confirmed cases in the last 24 hours, the top 5 states are Kerala, Karnataka, Maharashtra, Tamil Nadu, and Madhya Pradesh. If you look at the deaths, out of 1,055 deaths, Kerala with 595, Maharashtra with 81, Karnataka with 53, West Bengal with 35, and Gujarat with 35 in the top 5 categories. If you look at the tests per million per day, we find that the laggard states are West Bengal, Andhra Pradesh, Rajasthan, Meghalaya, and Assam. But in the top, we find Jammu Kashmir, Mizoram, Chandigarh, Kerala, and Delhi, who are performing tests above the national average. If you look at the test 7-day average test positivity rate, Kerala is at the top with 41.7%, Mizoram is 29%, Pondicherry 22%, Chhattisgarh 20%, and Andhra Pradesh 20%. Indian average is 11.4%. The growth of active cases in percentage is minus 5.69%. Almost all the states except Kerala, Mizoram, and Manipur are at the moment in the negative state. That means the infection is coming down, but the macro figure, as we shall see, the districts state-wise, where the test positivity rate is above 10% in subsequent slides. Next slide, please. Now, few slides on the deaths analysis. Officially reported COVID-19 deaths in India crossed 500,000, that is more than 5 lakh. Although many studies estimate the true number to be between 3 to 4 million, that is 30 to 40 lakhs. This chart shows percentage share of reported deaths and compares it with the percent adult population in each state. And you find the dark blue is share in deaths in percentage, and light blue is share in adult population in percentage. And you find the difference. How state after state, there is a sharp difference in terms of percentages. Next slide, please. Some states stand out on the previous chart. Kerala, with only 2.84% of adults, has reported 11.3% of all deaths. Maharashtra, with 9.7% adults, reported 28.6% of deaths. Uttar Pradesh, with 15.7% of adults, reported only 4.7% of deaths. Bihar, with 7.8% of adults, reported just 2.5% of deaths. Gujarat, with 5.2% of adults, reported only 2.1% of deaths. Rajasthan, with 5.5% adults, reported just 1.9% of deaths. Telangana, with 3% adults, reported only 0.8% of deaths. So you see the reverse pattern in Uttar Pradesh, Bihar, Gujarat, Rajasthan, and Telangana from what we see in Kerala and Maharashtra. Next slide, please. Now, take a look at the number of doctors per 10,000 population in each state. At the top, which are the states? Kerala, Jammu Kashmir, West Bengal, Tamil Nadu, Andhra Pradesh, northeastern states, and Telangana. But at the bottom are Jharkhand, Odisha, Assam, Rajasthan, Himachal, Punjab, Chhattisgarh, and Uttar Pradesh and Bihar. Next slide, please. Here, take a look at the percentage of deaths usually registered in each state, even during a normal year. This data is from CRS report 2018. The observation is, in general, states with relatively better healthcare infrastructure and death registration have reported a higher percentage of deaths in comparison to their share in the adult population. That's important observation for normal times. Next slide, please. This is another important data that is available in the public domain, that some of these states have largely underreported the deaths is obvious from the fact that they have approved COVID-19 ex gratia compensation claims many times higher than their officially recorded deaths. Now, this is a significant evidence that the deaths remaining unreported in state after state is a significant number. So this needs data collation, a comprehensive review, and sooner or later a reconciliation of the deaths that have occurred during the COVID-19 pandemic. This is important for not only managing the current pandemic, but preparing better for the future pandemics. We should remember this is not the last pandemic. Next slide, please. Now, let's listen to DG ICMR, Dr. Balram Bhargav, where he talks about a significant observation for the Omicron during the pandemic, what research has been done, and what is the evidence available during the last 1 month.
Now I will talk to you a small study that we have looked at from the National Clinical Registry of COVID. Look at the data. So now we have collected data of hospitalized patients from 37 hospitals, and these were the hospitals which were helped us in the plasma study, which we did across the country in 2020. These were the study which had given us the hospitals which had given the registry data, comparing the first surge with the second surge. And now we are looking at, these are hospitals, both are represented from India, from north, south, east, west, central, and northeast region. Next. And in this, there were 2 time periods which we studied. One was 15th November to 15th December, which was presumed to be dominant strain of Delta, and 16th December to 17th January, which is presumed dominant strain being Omicron, as we have available from our INSACOG data. Next. So this is just a snapshot of the paper has been sent for publication, so we are just sharing with you some of the salient features. And 1,520 individuals were hospitalized, and their mean age during this third surge was lower. So the mean age was about 44 years. There was a much slightly younger population. Having said that, the comorbidities present in this younger population was pretty high. About 46% had comorbidities. This is people who are younger than around 44 years, but nearly half of them had some comorbidities. And the predominant symptom, their symptoms were much less, but the predominant symptom which was higher in this population during the January period was of sore throat. Sore throat was more common than the earlier. Next please. And if you look at the outcomes was that if the death was 10%, this is hospitalized patients, compared to 22% in unvaccinated. And here we look at that 91% of these people who died, fully vaccinated, had comorbidities. And unvaccinated, 83% had comorbidities. And the requirement of mechanical ventilation was also much lower, 5% versus 11% in the fully vaccinated. So this is just emphasizing the fact that vaccination helps, and not having comorbidities also helps. So that is important to remember. So this is the last slide really summarizing what we have learned from this data of 37 hospitals, that younger patients during this third surge, 44 years versus 55 years earlier, comorbidities were 46%, so higher in this very young population. All symptoms in lesser proportions, we know that. and mainly sore throat. We also found that there was a significantly lesser use of drugs during this surge and significantly improved outcomes with much lesser complications of renal failure, ARDS, and other complications. So the last line is really important because unvaccinated versus vaccinated, death was 10% versus 22%. And the comorbidities were 91% and 83%. So really 9 out of 10 had comorbidities in this young population who died and was vaccinated. Unvaccinated, 83% had comorbidities. So vaccination and not being vaccinated and having comorbidities really are the drivers which decide the course of the patient during the hospital being adverse. So that is the summary. Thank you so much.
So you've seen a significant evidence that vaccination works. It works in saving your life. It works in improving the outcome of COVID-19 infection. And ultimately, you must get vaccinated. It will help you in tackling COVID-19 infections. As the WHO DG was mentioning about COVID-19 waste, how important it is to manage properly the COVID-19 waste that we have generated during the pandemic. We need to attend to the extra waste generated by the COVID-19 response. To be resilient, green, and minimize waste, health system and facilities must follow the waste management hierarchy. That is prevention, that is rational use. For example, do not use gloves if not needed. Second, preparing for reuse, that is invest in safe, reusable products and decontamination system. Third, recycle, that is support recycling systems and products. Fourth, recovery byproducts with recycled and biomaterials. And fifth, invest in well-managed landfills and waste workers. So all these 5 combination, waste and non-waste combination, shall ensure that we remain resilient, green, and minimize the waste. As you will see in subsequent slide, the evidence of what we have been doing during the pandemic in the last 2 years. Next slide, please. The extra medical waste created by COVID-19, testing, treatment, and vaccination has strained. All medical activities that create waste need to resource solutions to address it. This helps keep the patients safe, protect the environment, and reduce climate impacts. So keeping health workers safe and protecting the environment is possible and is a crucial part of our response to COVID-19 that must be remembered by all the people involved in managing COVID-19 pandemic all the time. Next slide, please. The COVID-19 response is generating a mountain of extra waste. Non-essential personal protective equipment makes up nearly half of all the volume of the waste. It is 38,000 tons, and essential personal protective equipment is 49,000 tons. Next slide, please. Certain increases in the volumes of healthcare waste from the COVID-19 response exposed cracks in waste management systems everywhere. The COVID-19 pandemic has generated extra tons of waste and exposed cracks in the waste management everywhere. Waste must be reduced and managed safely for the health of both people and the environment. It's of utmost importance now more than ever in the past. Let's learn the lessons from the pandemic. Let's now see the data from Southeast Asia region for the last 7 days. Following an increase in the number of new cases over the past month, the number of new cases in the Southeast Asia region decreased with over 2.1 million new cases reported this week, and an 8% decrease as compared to the previous week. However, 7 out of 10 countries in the region reported an increase greater than 20% in the number of new weekly cases, with the largest increases reported from Timor-Leste with 1,280% increase, Indonesia and Bangladesh, and the highest number of new cases were reported from India with 18,55,000 new cases with 12% decrease. Bangladesh, 1 lakh cases with 49% increase. And Indonesia, 56,800 new cases with 286% increase. The number of new deaths in the region increased by 41% as compared to the previous week, with over 5,200 new deaths reported. The highest number of new deaths were reported from India, that is 4,682 with 40% increase. Bangladesh with 140 new deaths with 77% increase, and Thailand 125 new deaths with 17% increase. And you can see the graph of the pandemic at the bottom with black line of deaths and blue or purple shaded portion as the cases. Next slide, please. This is the COVID-19 dashboard of the World Health Organization taken about half an hour back. There's the rank of newly reported cases in the last 7 days is country-wise is visible on the second column from the left. Overall, in the past 7 days, there have been 2,10,13,000 new cases reported, out of which 26,48,000, the top country was USA. Second country was France with 19,53,000 cases. India was at third with 13,30,000 cases. Brazil was at fourth with 12,57,000 cases. And Germany was number fifth with 12,42,000 cases. Russian Federation, Italy, Turkey, UK, and Japan followed from number 6 to 10. Next slide. This is the ranking of the countries according to newly reported cases during the last 7 days. Last 7 days, the world reported 70,000 deaths, out of which USA reported 18,254 deaths, India reported 7,700, Russian Federation reported 4,500, Brazil 4,500, Italy 2,575, and Argentina, UK, Colombia, France, and Peru reported more than 1,000 deaths from number 6 to 10 rank in the world. In the last 24 hours, 11,000 deaths have been reported, out of which 3,636 deaths have been reported by USA. Next slide. This is the situation as on date, where you see Europe, the cases have been reported with 15 crore 15 lakh, Americas number 2, 13 crore 80 lakh, Southeast Asia region 5 crore 30 lakh, Eastern Mediterranean 1 crore 93 lakh, Western Pacific region 1 crore 64 lakh, and Africa 81 lakh 32,000. And you can see the graph of the pandemic and how all the waves, first, second, and third wave, were hugely surpassed by the fourth wave, which is currently in progress across the world. So we are actually in the eye of the pandemic. The highest concentration of cases in the world is at present. Next slide. Globally, during the week 24 to 30th January 2022, where the data has been collated and collected across the world, the number of new COVID-19 cases remained similar to the number reported during the previous week, while the number of new deaths increased by 9%. Across the 6 WHO regions, over 22 million new cases and over 59,000 new deaths were reported. As of 30th January 22, over 370 million confirmed cases and over 5.6 million deaths have been reported globally. At the regional level, increases in the number of new cases were reported by the Western Pacific region, 37%, the Eastern Mediterranean region, 24%, and the European region, 7%. While decreases were reported in the region of the Americas, 20%, and the Southeast Asia region, 8%. The number of new cases reported in the African region remained similar to that of the previous week. The number of new weekly deaths continued to increase in the Southeast Asia region, 41%, the Eastern Mediterranean region, 32%, and the region of the Americas, 16%. While the African region reported a decrease of 7%, the incidence of deaths remained similar to the previous week in the European and the Western Pacific region. At the country level, the highest number of new cases were reported from the United States of America, 34% decrease, France, similar to the previous week's figures, India, 12% decrease, Brazil with 56% increase, Germany with 48% increase. The highest number of new deaths were reported from the United States of America with 5% decrease, India with 40% increase, the Russian Federation, similar to the previous week, Brazil, 88% increase, and Italy, 7% increase. Next slide, please. This is the situation of the COVID-19 confirmed cases and deaths by WHO region as on 30th January, where the complete data has been collated. And you can see overall new cases globally less than 2% decreased and deaths increased by 9%. Next slide. This is the map of the world with COVID-19 cases per 1 lakh population reported by the countries. And you can see the dark brown color where the maximum deaths per lakh population have occurred. And you can see the color is across the continents and across different countries, especially if you see the entire Europe is brown, the entire South America is brown, entire Australia is brown. Next slide. Now, let's see the Omicron variant. Since the designation of B.1.1.529 as a variant of concern 26 November 2021, several Omicron lineages have been identified. These include Pango lineages, BA.1, BA.1.1, and BA.2 and BA.3, which are all being monitored by WHO under the umbrella of Omicron. The common origin of these lineages has not yet been elucidated, and it is not clear to date how and where the Omicron potential parental variant or the descendant lineages originated and further evolved. The Omicron variant defining constellation of mutations fully overlaps with Pango lineages, that is BA.1, including lineage BA.1.1. And this accounts for 96.4% of sequences submitted to GSAID as of 31st January 2022. Most evidence we have to date about Omicron is therefore based on this Pango lineage. A relative increase in the BA.2 variant, which differs from BA.1 in some of the mutations, including in the spike protein, has been observed in multiple countries. BA.2 designated sequences have been submitted to GSAID from 57 countries to date, with the weekly proportion of BA.2 relative to other Omicron sequences rising to over 50% during the last 6 weeks in several countries. Investigations into the characteristics of the BA.2, including transmissibility, immune escape properties, and virulence, should be prioritized independently and comparatively to BA.1. It is important to consider the relative proportion of BA.1 and BA.2 sequences in the context of the case incidence when interpreting the data. So this is important observation for this week. Next slide. This is the COVID-19 deaths per 1 lakh population reported by the countries, and dark blue is where the maximum death per lakh population will occur. If you see, most of the Europe, especially Russia, United States of America, southern part of South America are having the largest concentration of deaths per lakh population. Next slide, please. This is the prevalence of variants of concern of Delta at the top and Omicron at the bottom in the last 30 days. And you can see yourself how the Omicron variant is so dominant across the world, including India. Next slide. Now we take a look at the districts in India where the weekly district-wise positivity rate is more than 10% during the past 7 days. State-wise, if you see Andaman Nicobar, in Nicobar it is 12%. Andhra Pradesh, in each state you will see the right column indicates the districts with the highest concentration, highest weekly district positivity rate from highest to lowest. The two columns, if you see on the left of this positivity rate, are the composition or the percentage contribution by rapid antigen test and RT-PCR. Rapid antigen on the left and RT-PCR on the right. So you can have total interpretation. So Andhra Pradesh has East Godavari 34%, Visakhapatnam 29%, and West Godavari 27%. In Arunachal, we have Upper Siang 77%, Dibang 68%, Upper Subansiri 45%, Changliang 36%, Namsai 34%, West Kimang 32%, Tirap 32%. So you can see Arunachal Pradesh is having very high test positivity rate. Next slide, please. Let's look at Assam. Assam has Charaidev 22%, Dima Hasao 20%, Kamrup Metro 18%. In Chandigarh, it is 11.25%. Chhattisgarh, in Kotagaon, it is 7.7%, Durg, it is 15.8%. In Delhi, South Delhi is still having 12.57%. In Goa, North Goa is having 28% and South Goa is 22.5%, a state going for election shortly. In Gujarat, Vadodara is having 26.63, Ahmedabad is having 22.47. Next slide, please. In Haryana, Charkhi Dadri is having 67.9%, Kaithal is having 31.99%, Faridabad is having 22.47%, Hisar 21.4%, and Sirsa 21.05%. If you look at Himachal Pradesh, Lahore and Spiti, highest in the country, 85% positivity. Bilaspur 34.9%, Kullu 29%, Mandi 25%, Hamirpur 25%, Shimla 25%, Kinnaur 23%, and Sirmaur 21%. Next slide, please. Karnataka, Mysore is having 25.87, Bagalkot is having 24.3, Tumkur is having 24.1, Kodagu 23, Chamrajanagar 21, and Shivamoga 20%. In Kerala, Ernakulam 53%, Kottayam 52%, Idukki 48%, Alappuzha 48%, Kollam 47%, Thrissur 46%, Palakkad 45%, Thiruvananthapuram 45%, and Wayanad 44%, and Pathanamthitta 43%. You can imagine the test positivity rate is so high across various districts in Kerala. Next slide, please. In Ladakh, Leh Ladakh is 20%, and Madhya Pradesh, Bhopal is 26.4%, Siori is 20%, Sirhor is 19%. Next slide, please. In Maharashtra, Nagpur is having 33.9%, Amravati 30%, Aurangabad 28%, Wardha 28%, Pune 27%, Nasik 25%, Nandurbar 24%, Sangli 22%, and Yavatmal 21%. In Manipur, Imphal is having 23%, and Kamjong is 23%, and Karching is 20%. In Meghalaya, West Garo is 20.59, Southwest Khasi is 17.7. Next slide, please. Mizoram, we look at Aizawl, the capital, 48%, Lungli, 41%, Champhai, 35%, and Nagaland, Peren, 50%, Mon, 26.32%. In Kohima, it is 17%. In Odisha, Khurda is having 17%, Sundargarh is having 11%. Pondicherry itself is having 29%, Karaikal is having 22%, while in Punjab, where the state is going for elections, SAS Nagar 18%, Bathinda 14%, Muktsar Sahib 11%. Next slide. Rajasthan, Jhalawar is 47%, Bundi is 38%, Jaipur 29%, Udaipur 25%, Jodhpur 24%, Dungarpur 24%. Sikkim, East District having 26%, South District 21.7%. Next slide, please. Tamil Nadu, Krishnagiri is 24%, Ranipet 17%, and other districts more than 10%. Uttar Pradesh, Gautam Budh Nagar, that is Noida, is 17.9%. Uttarakhand, Rudraprayag 22.68%, Nainital 13.3%, Pithoragarh 13%, and other districts are listed. Uttarakhand, Uttar Pradesh should also be going for election. And West Bengal, Darjeeling is 12.6%, Kolkata 12.5%, and overall India is 10.13%. These are 176 districts which are having test positivity rate during the last 7 days more than 10%. 276 districts out of 750 districts in India are having positivity rate more than 10%. Next slide, please. Attention is the rarest and purest form of generosity. Thank you for your attention.
Thank you, Dr. Rajiv Jain, sir. Yes, the COVID pandemic, it is still persisting, and as WHO reiterated that we should continue with our efforts to mitigate it, and slowly only the restriction should be lifted at different places. Any questions, sir? If you have any queries, Kumar, sir?
Yes. First of all, wonderful presentation, Dr. Rajiv Kumar Jain. My compliments. Now, the question is, can we see there are two aspects as far as management of COVID is concerned. Not only management, the response of the public is concerned. Number one, there is a ultimate fatigue out of the restrictions of COVID in the general public, and people are now taking things lightly. And there are relaxation from the government side as well. School and colleges are going to open from next Monday. Gyms, spa and everything is going to open in Delhi at least from Monday. So can we consider that the peak is over and now we have to live COVID as an endemic disease? What is your, say on this?
Well, very relevant question, but the data that I presented district-wise the last 7 days is to the contrary. India is still in the thick of the pandemic, as district after district within the states, you find the infection rate, positivity rate is more than 30%. In, like you saw, Lahore and Spiti, 85%. So one has to be on guard. We are very much in the pandemic, and WHO also highlighted we need to analyze BA.1 versus BA.2 in the Omicron wave. This is the Omicron wave. And there are pockets in the country and which have very little immunization. That also is an area of concern. So it is graded response, which is required. Each district has to take a very dynamic stand and also ensure that it is driven by evidence that is collected. If you do not collect evidence, nothing will change. But one needs to collect evidence and then act on that evidence on a regular basis, on a continuous basis. Whether it is said by WHO or ICMR or Government of India or the state government, the fact remains this infectious disease requires response at the micro level, that is district and sub-district level. And that is the reason I've shown you the test positivity rate across states and across districts, which shows you the glaring disparities in state to state. And that was precisely the reason I showed you the evidence for the deaths. Maharashtra and Kerala, because they, in the normal time, their system of registration of deaths is very much established, so it was working fine. But in normal times also in UP and Bihar, the death registration system was not working properly. So during the pandemic, it gets further heightened. So both the issues are related to each other. Pandemic management is driven by evidence. If you do not collect evidence, do not system to collect evidence, you will not be able to manage pandemic. Wave after wave, it will continue. Deaths will continue occurring. If you remember, India has reported more than 1,000 deaths in the last 24 hours. And across the week after week, India continues to report in the top 5 countries in the world. So India and USA have always been in deaths in the past 6 months at the first and second position. So we need to be on guard. We are very much in the thick of the pandemic. No permanent relaxation, no permanent tightening of the control measures. It is a dynamic situation. Try your action based on evidence.
Right. Thank you.
Yes, we have to decide on our actions based on the evidence. That is rightly said. And Dr. Shiva Ramakrishnan, sir.
Good evening.
Good evening, sir.
As usual, Dr. Rajiv Jain is always excellent. So thank you, Dr. Rajiv. Now, I just wanted to remind all the people who have registered for ICO 2 2022. The voting will start tomorrow at 8:30 p.m. onwards. So kindly please vote for us. Our country has to get it. It all depends on your support. So that is what I wanted to inform. The links, everything is available. So kindly vote. Thank you.
Dr. Sandeep, Dr. Jamdulera has raised a question in the Q&A box.
Yeah.
He has asked a common complication during Omicron variant COVID infection in the patients with comorbidities and fatalities post-Omicron variant. Very relevant question. This data is at the moment under collation, and one of the evidence that you saw, ICMR DG presented. The complications are need for oxygen, mechanical ventilation, and intensive care facilities. So the person who is having comorbidities, who is not vaccinated is the most vulnerable. That is the evidence currently available, but it is a continuous process. Government of India, along with ICMR, are in the process of collating this data on a continuous basis. Thank you for asking this question.
So yes, this ICMR, they have done this research also. Soon they will be publishing it that unvaccinated people and people with comorbidities, they are the most affected people. And same way, in the hospitalized cases, more ventilation is required. More is the duration of their hospital stay. More are the complications. And what the important point which you have raised today, sir, that is the cracks in the waste management, biomedical waste management, that is very important. And effects on the environment of this COVID-19 waste, which is like 38,000 tons of the PPE waste and 48,000 of other waste. So these are all contaminated waste, which is adding a burden on the biomedical waste management of various countries. So let us learn from the pandemic, and we should try to mitigate at our respective workplaces and our local areas based on the evidence, like Dr. Rajiv has told. We have to be very particular in taking COVID pandemic lightly, and don't be complacent. Try to maintain all these norms wherever possible. Dr. Tyagara sir, he has raised his hand. You want to say something, sir?
Good evening, sir. I think what Dr. Shivram Krishnan, our senior most leader of our IAOH, and he was the past president, past general secretary. I have seen him as a general secretary in the Bangalore conference, and he's a very good friend of all of us. I think he has appealed to every one of you to vote for our HICO to the India. I think this is the very fair chance for us, and if we get it, I think we will be very proud. Now, I just wanted to ask Dr. Rajiv Jain, sir, will you please elaborate about the Omicron subvariant BA.29? Everybody is telling, but the genomic study is not so much so. What we heard in WHO, what we heard from you is the only thing. But in NDTV, we are listening. But how it is it affecting India? Is it there in India? Will you please highlight, sir, about this Omicron subvariant BA.29? Dr. Rajiv Jain, sir.
Thank you, Dr. Tyagarajan. The subvariant BA.2 is the issue versus BA.1 within the Omicron variant from the Pango lineage. India, under the IGs of NCDC, is been analyzing the subcomponent of the subvariant on an ongoing basis. And if you go to GSAID website, GISAID website, you would see accurate data available, and it's available to the public. Just Google GISAID and you will get India's data as well. It is on a continuous basis. India is feeding the data. In fact, India is one of the largest centers outside UK for reporting to the GSAID the subvariants also. And that is, I feel, India's strength in genomics. It is showing in the global analysis of evolution of Omicron variant as well. BA.2 is now becoming increasingly dominant amongst the subvariant. Earlier, it was BA.1, but in India as well, BA.2 is now starting to dominate.
Thank you very much, sir.
Thank you, Dr. Tyagara, sir. So I think with this, we can conclude this session. It is almost more than about quarter to 2 hours. And as requested by Dr. Shiva sir and Dr. Tyagara sir, yes, from tomorrow onwards, this ICO 2022 Great Feast is starting, and we all should, who all have registered for this conference in good standing, they should attend, and they should definitely vote for IUH bid. And this is a fair chance for every one of us. We have got 194 members in good standing and 150 delegates. They have been registered from India. So it's a good chance for us, although we are bidding for the third time, but it is a good opportunity. We should definitely try to encash this opportunity, which is on digital platform. So with this, sir, I conclude this session with your permission.
Right.
We all
Thank
will
you.
next Saturday, sir. And from tomorrow, we all should be busy in ICO for next 5 days. And thank you very much, sir.
Thank you.
Thank you.
Thank you all.